Congenital dislocation of the hip has an incidence of about 1 per 1,000 throughout much of the world. Yet, in China, Hong Kong, Thailand, and India, CDH is virtually unknown, as it is in the tropical regions of Africa. We have been studying the high incidence of CDH among Indians in northern Saskatchewan. Near Loon Lake, at the Minnesticwan Indian Reserve, there is a prevalence of 35 per 1,000. At Puckatawagan, just over the border in Manitoba, the prevalence is 17.7 per 1,000. An environmental etiologic factor of considerable interest is the Indian practice of swaddling. On the Red Earth, these children are cared for during the first year of their lives in their cradle boards or ticonogans. This demonstrates the practice of swaddling. The legs are bound tightly together. The child cannot flex his thighs. Abduction and external rotation of the legs are impossible. Note that diapers are now used, though until 10 years ago, moss was used. It is of some interest that the high incidence of CDH in other parts of the world is also among those people where swaddling is a common practice. As mentioned, swaddling and CDH occur together among the Lapps of northern Sweden and Norway, in northern Italy, and in the mountains of southern Germany, and among the Navajo and Apache Indians of Arizona, all of whom swaddle their infants. We have demonstrated to you the high incidence of CDH in groups practicing swaddling, in particular in the Indians of northern Saskatchewan. In contrast, congenital dislocation of the hip is virtually unknown among those people in the warmer climate where the babies are carried on the mother's back or astride the mother's hip. Here the infant's legs are in marked abduction and external rotation, the very opposite of the tight swaddling in adduction used by the Indians. This is a very colorful sling. In Hong Kong, the only cases of CDH reported have been in babies raised in the Western style in a crib, babies who were not carried by this method on the mother's back. Even if the child had a genetic predisposition to CDH, or had generalized joint laxity, or had its hip ligaments stretched by the breech position in utero, and for any one of these reasons had a dislocatable hip at birth, this would be corrected by carriage in the backsling, since this is the treatment position for CDH. If begun soon after birth, this position would correct the dislocated hip, just as would immobilization in a fracas splint or in a plaster cast. If the Indians could be persuaded to carry their babies in the Chinese fashion, as the Eskimo mothers do under their parkas, presumably even those with a dislocated or dislocatable hip at birth would be corrected, and CDH would then become as uncommon among Indians as it is among Eskimos and Chinese. All newborn infants should have their hips examined, particularly those infants with a family history of CDH or familial joint laxity, those born by breech delivery, and all Indians. Disability from CDH is now preventable.